It's often pointed out that significant numbers of people in sub-Saharan Africa never meet a doctor or nurse in their entire lives.
57% of people in Uganda still don't ever see a health worker. They go to a traditional healer. They see people going to hospitals and coming home in a box because they go so late that they die.
And Merriman is a force of nature. She cannot be stopped. And she has energy that I haven't seen in anyone else.
The World Health Organization has made it clear that morphine is an essential drug for cancer pain relief. What we see in Africa, as in many other parts of the world, is that many problems and barriers in getting access to morphine. Although it's a cheap drug, it's easy to produce, and it's relatively easy to administer in trained hands. At the moment, many people who would benefit from it are not receiving it.
Across much of Africa, there is a plight of pain and suffering. Famine, war, civil unrest, disease. Many nations struggle to provide even the most basic support for their people. Uganda is one such nation. Since the fall of Idi Amin and a civil war, Uganda has struggled to provide adequate and affordable health care to its 32 million inhabitants. The average life expectancy is 54 years. In sub-Saharan Africa, more than 20 million people are living with HIV/AIDS, and there are over 15 million AIDS orphans. In Uganda, in the 1980s, 30% of the population were infected with the AIDS virus. Now, a rare success story in Africa, the number is closer to 6%. But still, over 60,000 people die of AIDS-related illness in Uganda every year. Cancer is also prevalent. In the country villages, there is only one doctor for 50,000 people.
There's only one cancer centre to serve over 30 million people, one trained oncologist, one radiotherapy machine.
Throughout Uganda, nearly 100,000 cancer patients need urgent access to basic pain control. Due to the lack of medical services, extreme poverty and poor education, tumours can disfigure, rupture and cause unimaginable pain. This film documents the scourge of cancer in Uganda and the devastating effects caused by the lack of treatment and pain control. With only one treatment centre in the capital, Kampala, chemotherapy and radiotherapy is unavailable to most. One hope for those suffering from cancer is work done by the hospice movement, in particular Anne Merriman and the organisation she helped to create. Hospice Africa Uganda has been building a unique palliative care service for the past 20 years.
When we work out the number of people in Uganda at the moment who need pain control at this moment, it's something like 200,000 people. Now, we have one doctor to 19,000, but in the villages it's 1 to 50,000. To them, cancer means pain and a terrible, terrible death.
This former nun is regarded as the pioneer of the hospice movement in Africa. In 1990, she was appointed the medical director of Hospice Nairobi, and during this time, she realized the extent of the suffering and the lack of care available for patients dying with cancer in Africa.
People were suffering all over Africa without any pain control, some of them screaming actually, and the families having to put them far away so that even the family carers could sleep at night. And I realized that this was something that had been going on for all these years. We really needed a model that would be adaptable to the cultures in Africa. And so I left Nairobi Hospice and spent a year trying to get together a group that would support us to start, and also to find out which country we would start in.
Although a poor country, Uganda has a good climate for agriculture, favouring the production of such crops as bananas, sugarcane, coffee and tea. It was here that Anne Merriman convinced the government to let her establish a model for hospice care for the whole of Africa.
We chose Uganda because it had just come out of war. The people were very, very enthusiastic and very caring for each other. And although there was you could see it was a poor country and you could see bullet holes in the buildings in Kampala, there was a feeling of hope in the country, and they had the trust of the international community, so we knew we'd be able to get funding. The three objectives was, first of all, to care for patients, and this is what we call clinical care. The patient care was to care for patients who particularly had severe pain, were critically ill in the home, or were at the end of life. The second one was to have training so that every health worker throughout Uganda would be able to manage a patient or at least refer them to the right service. The third one was to be a model for the rest of Africa.
This is the centre of operations of Hospice Africa Uganda. It provides clinics for patients who are well enough to travel and a daycare centre. Since 1993, Hospice Africa Uganda has opened 3 care centres across the country, in Kampala, Mbarara and Hoima. Nearly 1,000 people with cancer or HIV/AIDS are on the hospice programme. Another 1,500 patients have access to pain control from medical workers trained by Hospice Uganda. Home care teams leave from here each day to visit the patients who are too unwell to make the journey to the centre.
The idea of visiting patients at home is really intended for the very ill people who are simply too unwell to either travel to a clinic or to any other healthcare facility. And oftentimes those people will be bedbound because of their illness. So the teams will travel out, will visit at home, see how the person has been since the last visit, see how the family are doing, and depending on what issues present, will prescribe and leave medication with them.
After negotiating with the government, Dr. Merriman managed to get a licence to import the much-needed morphine.
One of the big problems in providing any kind of healthcare in Uganda is the cost. Resources are extremely limited, and one of the drugs we absolutely need to have to provide palliative care is strong pain medicine. And what Dr. Merriman found when she started first was she'd had access to a formula for making up morphine, which she'd first learned in Singapore. But it means that morphine can be made up quite cheaply in Hospice Africa Uganda through importing powder from Europe and then reconstituting it with preservative and food dye in Hospice Africa centres.
We use now about 2 kg a month, which costs about nearly £3,000 a month, but in fact, when you work it out for the patients, it costs the price of a loaf of bread for medication for approximately 10 days for the average patient. Our average patient is taking 30 milligrams a day. It means now that the patients can go home and have their pain controlled in the house. Many of these patients have gone back to work because the pain is now completely controlled.
Recycled plastic water bottles are filled with brightly coloured solutions. The bottles are full of oral morphine, colour-coded for the different strengths. Green for the weakest, then pink and blue for the strongest.
The nurse prescribing arose because there was a terrible need for people to prescribe. When we work out the number of people in Uganda at the moment who need pain control at this moment, it's something like 200,000 people. Now, these doctors out there have to do the gynecology, they deliver the babies, they do the cesarean sections, they do the surgery, the major surgery, and they look after the children who are very, very ill, and, you know, so they have so much to do, and that they could not prescribe for maybe 100 patients a week for morphine. So we had to increase the prescribers. So we put this across to the Ministry of Health, who took it to the Parliament, and they had this statute which allows midwives to prescribe pethidine for women in labour. And we asked them to change it so that people who we trained for 9 months in palliative care and in prescribing could prescribe morphine. So now we are increasing the prescribers slowly by slowly, very slowly.
In a busy western suburb of Kampala, Mulago Hospital has a cancer treatment centre. Burkitt's lymphoma is a curable form of cancer that doctors often see.
Burkitt's lymphoma is extremely common in Uganda and actually in a belt across Africa, and so much so that Burkitt, who actually described it first in Uganda, thought that it was related to the mosquito or to malaria or the Epstein-Barr virus, and we've never actually got to the bottom of it, what it is really related to. But it's a tumour of the lymphatic cells, and many of the children present with a huge growth on one side of their face.
Hospice team member Dr. Charles visits the centre 3 times a week. The hospice provides not just pain control, but also pays for the first course of chemotherapy in an effort to cure these children.
Okay. The mother is telling me that he's now feeling a lot of pain. The tumor was a bit small, but now it is increasing in size. Otherwise, she has been here on the ward for the last 3 months. She has been here on the ward. Yeah. Leaving her family at home. They have these kind of deadly diseases, but affording the treatment is a problem. It's a problem. Most of our children on this ward, they come from very poor backgrounds. I should say like 95%, they are below the poverty line.
It is actually a highly curable tumour, provided they have the right chemotherapy. And a course of chemotherapy over 6 months costs approximately 100 to 200 euros. But the majority of parents bringing their children to the Cancer Institute can't actually afford that much for chemotherapy. And I think it must be absolutely unimaginable to be a parent and to be told that your child has a curable tumour, but to find that they're going to die because you can't afford the medication for them.
Think about freedom from pain and access to pain medication as a fundamental human right. A number of lawyers, philosophers, activists of various kinds are working towards building up a case for the recognition that freedom from pain and access to pain medication is a human right. This is a much more powerful argument than we've ever had before, and it's getting listened to in places where palliative care was previously ignored.
They've produced a template that works. And they came up with an idea, they set up the program, and they've proven that it works over several years. And from the very start, they've thought big in that they said, right, we'll start this in Uganda, but very much with the intention of spreading this way of looking after people.
It's really working in Uganda, and it's working in every part of Uganda, and it's so important now that this model of hospice care can spread throughout all of Africa.
These are people who have vision, and they don't just look at what is there and say, this is good, let's leave it at that. They're saying, this is good, let's make it better.
Now, most people take aspirin when they have a headache, but in many parts of Africa, that is, in fact, the strongest drug terminally ill patients can get to ease the pain of dying. Morphine is available only to the rich.
But one woman from Liverpool has dedicated her life to changing that. And today, Anne Merriman received an honorary doctorate in recognition of her work. Eleanor Moritz reports.
Cancer touches billions of families, but the people of Uganda have suffered more than most. Treatment is only available for the privileged few.
They won't have chemotherapy and radiotherapy for another couple of generations because the money isn't there for that. And most of the time, they don't have enough money for the drugs. Would get aspirin or Panadol, and that was all.
Dr. Anne Merriman has dedicated her career to caring for the dying, setting up a charity, Hospice Africa.
It's only now that we've got the pain relief that people can die in peace with themselves, with their families and with their God. We went out in '93 with enough money for 3 months for 3 staff. The first year and second year it cost us about £24,000 a year to run. It was completely home care. Now it costs £2 million to run.
Shops like this one in Liverpool have helped to raise money for the care of more than 14,000 people in Uganda. The branches in Old Swan and Ainsdale are run entirely by volunteers.
The money that comes in here is for the charity.
For Africa, yeah.
For Africa.
Yeah.
And that's our biggest kick.
Yeah.
We know there's not money being wasted.
Dr. Merriman received an honorary doctorate today from Edge Hill University at Ormskirk.
This is why this is so wonderful that it's in Liverpool. It makes the people in the shops realise how much they have contributed. And this honour is not just for me, it is for the people who have supported me.
It's all it deserves.
Generous to a fault. Love it to bits, yeah. It's great. And that's why we're all here.
The charity hopes to expand its work to help the dying in countries across Africa. Eleanor Moritz, BBC Northwest Tonight.
At Queen Elizabeth Central Hospital, in the Department of Medicine, one of the services that's offered is a palliative care service. So we cover palliative care needs of adult patients who are on the medical wards. What we aim to do in palliative care is to improve quality of life, and often that's through pain relief. There is a need for us to improve patients' awareness that pain can be managed effectively over the short or the long term, so that they present when they have problems and that we see them and we try and manage those pain and other symptoms to the best of our ability. I think one of the major benefits of the palliative approach is that we seek to give holistic care to patients. And many of the patients' outcomes are not so much determined by their medical condition as by their social setting. So do they have a guardian, for instance, to look after them in hospital? Do they have enough food to support their nutritional needs? Do they have a mattress to sleep on at home? Is their pain properly managed? So those are the kind of things that in palliative care we can look at. And obviously we can also offer that continuity of care from the hospital back to the home setting, which patients and their families really appreciate a lot. In the home setting, we're mainly reliant on a full-time basis for the home-based care volunteers. So they're people that live in the community, so essentially the neighbours, friends and family of the patients who are going to be doing the full-time care. Some of those we've trained in certain areas, others have been trained by other organisations. And we go in to really be a link to the medical aspects of the care, so the pain relief that the patients will need on an ongoing basis. We would go in and review the patient and the nurses will continue the care along with the home-based care volunteers.
What about pain? Are you feeling pain anywhere?
No, I'm not feeling pain. No.
Are you taking your painkillers?
Yeah, I'm still using some painkillers, but not for headache. Yeah.
Wisdom Moyo is a 24-year-old gentleman. He's Malawian. We first met him when he was an inpatient in the hospital. He was referred to us because he had a very severe headache which was not controlled. And during the course of the investigation, he was found to have a primary CNS lymphoma. He had recently come back to Malawi from South Africa, so he's actually left a wife and children in South Africa. He was a migrant worker down in South Africa. Since that time, unfortunately, he also presented about a month ago with a left-sided stroke, and we weren't sure if this was a new episode of stroke or if it was perhaps related to the lymphoma.
What did they find? Do you know, or were you told what was the findings in the head?
They find the cancer problem.
Mm-hmm.
Yeah.
What do you understand when you say cancer? What were you told?
I was worried so much, but there is nobody who can help me about cancer problem. I leave everything in the hands of God to protect me, because there is no anywhere I can find the treatment of cancer.
In the context of having an aggressive lymphoma which has a poor prognosis, we wanted to talk to him about those issues relating to his family and seeing his family members.
I miss my wife and my kids because there is nobody who can support them than me.
Okay, so you were the breadwinner?
Yeah.
The one who's getting money?
Yeah.
Is your wife working?
She was working, but it was temporary.
Here in Malawi, the other range of treatment options are not available, so we perhaps pick up people, obviously many people with advanced disease, but we pick them up perhaps earlier. We try and control their pain and symptoms to improve their quality of life, make their life worth living, but that end-of-life care is mainly done in the community with family, friends and the home-based care volunteers.
We are very happy because of you are visiting us to take time chat with us.
Thank you again. See you.
Within the context of Malawi, many people want to be buried in the village, so if we can help people to get to the village before they die, from a very practical point of view, it reduces transport costs, because it's cheaper for a live person to get to the village than it is to carry a body in a coffin in a truck to the village. Traditionally, people are buried in the village in Malawi, so that would be a best place for them to be before they die.
At some point, we are all going to die. And if you're dying from a sickness or an illness, you're probably going to have a lot of pain. And in the United States, we don't think about it because, you just pull a button and somebody gives you a pain reliever. But around the world, in places like Uganda, there are people who are literally dying without any medication at all, which is a horrible way to even think of passing.
Because the only thing worse than dying of AIDS or cancer is to die of AIDS or cancer with no access to pain relief.
And we've talked to a number of people who said, without this morphine, I would have, no dignity. I would have a hard time getting through the day to day, hour to hour, minute by minute, because the pain is that great.
The thing about this problem, the lack of access to pain relief, is that there's a solution, kind of an easy one. And that's to get more medication to more people who need it.
How are you from Hospice?
They're wonderful people.